Rahul Banerjee from the Fred Hutchinson Cancer Center in Seattle, Washington, and it's my pleasure to present this data on behalf of my co-authors. This 24-hour urine testing did not add value to multiple myeloma response assessments, a secondary analysis of BMT CTN 0702. I'd like to acknowledge the BMT CTN who funded this trial, and this was a post-hoc analysis of that trial. So, in brief, as many of you are well aware, as of now, January 2025, IMWG response criteria do require 24-hour urine assessments as a component of VGPR, complete response, and PD determinations. And this can cause a lot of problems, right? On the bottom right, there's an example, as patients watching this will very well be aware of. That's what a 24-hour drug actually looks like, keeping it in the fridge next to their orange juice, water, milk, etc. And it's a lot, right? I know that it's a lot for my patients whenever I have to ask for it. It can cause discomfort for frailer patients, for example, those with neuropathy. Absolutely, collecting 24-hour urine specimens are harder for women than for men. For patients who don't have continual access to refrigeration, whether they're unhoused or working odd hours, that can be very difficult. Many times we've had patients who the response assessment on a trial is not complete, so to speak, because the urine is missing. And of course, the increased financial costs and research coordinator effort to go into this, not to mention the carbon footprint of all of these urine jugs. And so what we did was we went a step further compared to prior studies. So prior studies have looked at these specific elements. In the interest of time, I'll move on. But I think the bottom one I'll highlight that only 28% of US patients in the real world setting undergo any 24-hour urine testing at diagnosis. So this is not being done that commonly. In trials, the results above have shown that it's not that helpful. What we haven't really seen tested is this kind of an approach. Or what if we were to take the word urine out of response criteria, period? Again, this is hypothetical because right now urine testing is required as part of IMWG response criteria. But what if? What if we took out the requirement for urine immunofixation for complete response, took out these requirements for the urine M spike on Bence-Jones proteinuria for VGPR, for PR, and so forth? We had done prior data with this before at my prior institution, and we looked at real world data and found that only 4% of patients in the real world had their responses reclassified with these urine-free criteria, but the data weren't really robust enough for us to really look at, does this make a difference? Do urine-free criteria work as well as traditional responses to actually predict PFS, which is the whole point of these response criteria, to assess how long will someone stay in remission without progression thereafter. So what we did was a secondary analysis of responses from this BMT CTN 0702, the stamina study. There was a randomized study of one of 3 post-transplant strategies in myeloma. We looked at all patients who were randomized to any of those arms, excluding those who had progressive disease at the day 56 time point, because those patients clearly are a different category entirely, and the infrequent number of patients who were non-evaluable even for urine-free responses at that time point. We had the traditional responses, and then we went back and recalculated the urine-free responses with discrepancies reviewed by 3 of us. Because of how the study worked, because there was a long-term follow-up component and actually linked CIB-AMTR data to really, really track these patients on for years afterwards, PD, progressive disease, was defined using traditional criteria, not using urine-free. So in brief, 645 patients were 645 patients were evaluable. You can see there's a good mix of patients, including about a quarter of them with light chain only disease. Although it was meant to be 1-to-1-to-1 randomization between these 3 studies, about half of them ended up on lenalidomide alone as their actual what they actually ended up on. Only 1% of patients had discordant responses between traditional and urine-free response criteria. Importantly, this kind of went in both directions. Some patients who were deemed a VGPR because of missing urine immunofixation or slightly positive urine paraproteins became urine-free CRs. Some patients went the other direction. Remember that in traditional criteria, urine is deemed more important than serum-free light chains in current criteria. So this patient, for example, never had serum paraprotein. The urine paraprotein cleared, and therefore they were called, VGPR. It was missing a bone marrow. However, the light chains didn't actually go down that much. And most importantly to me, 4 of these patients, so over half of the discordant patients, were previously non-evaluable, and now they were evaluable because the requirement for urine didn't mess things up. This is important, right? We ask our patients very literally to donate their, blood, soul, sweat, and tears to participate in a clinical trial. And, these patients sometimes end up being non-evaluable. They do the trial, but the responses don't count. And so at least with these urine-free criteria, some patients went from quote unquote not counting to counting. Briefly here, I'll move quickly through these. These slides look very similar. So if you look on the left is urine-free response criteria, on the right is traditional response criteria. Because there were so few discordant patients, you can see that they did both very quite well. So on the left, urine-free response criteria, very prognostic for PFS with a hazard ratio of 0.83, p-value less than 0.05 between all four of these levels. If you were to compare just CR versus not, same thing. Even VGPR versus less than PR, borderline significance. So clearly, urine-free criteria can do the job. So in terms of what does this mean? So in data from a large phase 3 trial where patients were closely monitored and followed, removing urine criteria did not have any appreciable impact on the ability of these responses, urine-free responses, to predict PFS. Importantly to me, again, of the 7 patients whose responses shifted, 4 of them went from being non-evaluable, from quote unquote not counting, despite participating in the study, to counting. And I would argue that better reflects one, disease biology, but two, the generalizability of the trial, because if patients are on the trial, the results should be counted. There are some limitations, of course. As I alluded to, we use traditional criteria for progressive disease. It's pretty rare in the modern era to have urine-only relapses if you're routinely checking free light chains. And most importantly, this is not applicable to MGRS, monoclonal gammopathy of renal significance, for example, AL amyloidosis. In AL amyloidosis, I do routinely ask my patients to perform 24-hour urines. Still annoying, but there, I think they're very important for renal responses in a way that serum-free light chains are not. So in terms of next steps, so our results strongly support the planned de-emphasis of 24-hour urine requirements and future IMWG response criteria. The IMWG is working on this year, kind of as we speak. And our ideal state about this, and this is the data that I presented in ASH, that one, I would believe that we should remove, ideally, in my personal opinion, urine from myeloma response criteria, unless it's the only marker of measurable disease for them. Like obviously, if it's the difference between being non-secretory and measurable, then definitely use the urine. But most importantly, I'd love to remove it from refrigerators and emails about protocol deviations all over the world. This is one of my real life patients on the right, and something that I had to report to the sponsor. The patient had a protocol deviation again and again and again because they're not filling in the 24-hour urine sample. I don't blame them. It's hard. It's cumbersome. Hopefully, in the future, things will change. So with that, I'd like to acknowledge the patients who participated in this trial and funding for the BMT CTN 0702 study. And I thank you all for your time. Thanks again for listening.